So, good evening, guys. So, now today we are looking at the neurology OSCE for the DNB final year exam. So, let's start with the first question. So, the first question is a 50-year-old man presents with a drooping of eyelids, double vision, weakness, and fatigue. He reports that his symptoms are worse at the end of the day, and in the image, you can see the bilateral ptosis, right? And he is trying to lift the eyelids by raising his eyebrows, and he is using the frontalis muscle. So, what do you mean when the symptoms are worsening by the end of the day? The history is telling that the patient is having a fluctuating weakness. So, what are the questions? So, what is the most likely diagnosis for this patient? So, the most likely diagnosis for this patient would be myasthenia gravis, right? Since there is involvement of eyelids and diplopia in the sense there is ophthalmoplegia as well, right? So, the most likely diagnosis would be myasthenia gravis. And what are the main diagnostic tests for this condition? Second question. So when you do a bedside investigation, the bedside investigation would be a simple ice pack test where you'll keep a ice pack over the eyelid. Because of that low temperature, there is increased availability of acetylcholine in the neuromuscular junction, and there will be improvement in the weakness. Or you can also do the tensilon test where we'll be using an intravenous edrophonium, which is an acetylcholinesterase inhibitor, right? And in the serological tests, we can do anti-AChR antibodies or anti-MuSK antibodies if there is an ocular myasthenia. And you can also go ahead with the electromyography where you will be able to see a decremental response with the repetitive nerve stimulation test, right? Then third question is how do you treat the patient? So you will treat the patient by using the acetylcholinesterase inhibitors like pyridostigmine. And since myasthenia gravis is an autoimmune condition, you will also have to use immunosuppressants, that is prednisolone, along with some others like azathioprine and mycophenolate mofetil. The fourth question is how would you treat him when he presents to you in respiratory distress? Since we are talking about myasthenia gravis, if the patient directly presents to you in respiratory distress, it means that the patient is in myasthenic crisis. And for myasthenic crisis, what will you give? You will have to, of course, provide him with the oxygen support and all the um, in, intubation and mechanical ventilation. And along with that, you'll also give intravenous immunoglobulins and plasma exchange. So, what are some other differential diagnoses? The other diseases that will involve the neuromuscular junction are the Lambert-Eaton myasthenic syndrome, congenital myasthenic syndromes, or botulism, right? So when the question tells you that the patient is having some kind of carcinoma, most commonly small cell carcinoma, think about Lambert-Eaton myasthenic syndrome because it is a paraneoplastic syndrome. This is the second question. So the question says it is a 65-year-old man with a history of type 2 diabetes mellitus presenting with burning pain and numbness in his feet that has been worsening over the past 6 months. He is also reporting the difficulty in walking and maintaining his balance. So involvement of the burning pain and numbness shows that there is involvement of small fibers or the anterior spinothalamic tract involvement. And difficulty in walking and maintaining his balance shows that the patient is also having the posterior column involvement. So there is both the small fiber and the large fiber involvement. So the most likely diagnosis would be, since in the background of diabetes, the most likely diagnosis would be the diabetic peripheral neuropathy. So what is the test that is being done in the image? So this has also been asked in the previous exam. So what he is doing, what he is using is a monofilament test. It's being used to test the sensations in the plantar aspect of the foot, right? The next question is what are some possible conditions? What are the possible complications of this condition? Since the patient is not having any sensations, the patient may develop foot ulcers and infections because of the posterior column involvement. There can be falls and injuries. This peripheral neuropathy can also involve the autonomic nerves that can also result in variations in heart rate and blood pressure. Autonomic neuropathy can also be there in relation to the cardiovascular system, and there can be reduced quality of life because of pain. Okay, right? So I think this was a request that was told about medicine Osce's where then how would you manage this patient's pain? The drugs that you use are gabapentin, pregabalin, and along with that you can use antidepressants like amitriptyline, venlafaxine, and opioids, tramadol, oxycodone, and you can also use some topical agents like capsaicin and lidocaine. And along with that, you can use you can give the patient cognitive behavioral therapy and transcutaneous electrical nerve stimulation. So these are the modalities that you use for management of the patient's pain. So what are some other causes of peripheral neuropathy that should be considered in the differential diagnosis? They are the vitamin B12 deficiency, alcohol-related neuropathy, toxic neuropathy, or infectious neuropathy related to HIV or Lyme's disease, toxic neuropathy because of heavy metals or pesticides, and some inflammatory neuropathies as well, like chronic inflammatory demyelinating polyradiculopathy, that is CIDP, or neuropathy because of vasculitis can also have this similar kind of presentation. These are the answers again. Now let's move on to the next question. So a 45-year-old woman presents with sudden onset of right-sided facial weakness and drooping of mouth and the eyelid. She also complains of pain behind the right ear, decreased taste sensation on the right side, increased sensitivity to sound in the right ear. So what do you see here? In the image again, you are able to see that the patient is not able to close the eyelid completely, and you can see the lower bulbar conjunctiva is clearly visible, because it is a normal phenomenon of uprolling of eyelids when we close the eyes, but since the patient is not able to close the eyelid completely, we are able to see the bulbar conjunctiva, which is called as the Bell's phenomenon, right? It indicates the involvement of the upper half of the face. And you can also see the deviation of mouth to the normal side. Uh, so there is involvement of both upper half of face as well as the lower half of face. And in the question, it also says that there is decreased taste sensation on the right side of the tongue. It means that the patient is having also the chordotympani involvement on the right side, and there is increased sensitivity to sound, meaning there is involvement of the nerve to stapedius as well. So in the exam, you may not have all these. The In the exam, the question may be quite short. Maybe half of the question may be given, but still you may have to guess it since the image is quite clear. So what is the most likely diagnosis for this patient? The most likely diagnosis would be the right-sided element kind of facial palsy. It is usually idiopathic, and hence the diagnosis Bell's palsy, right-sided Bell's palsy. And what are the main risk factors for developing this condition? Of course, the commonest cause is the HSV1 infection, and along with that, the other risk factors would be diabetes mellitus, pregnancy, and immunocompromised states. So, what are the main complications of this disease? The main complications would be because the patient is not able to close the eye completely, the patient may develop exposure keratitis and corneal ulceration. And along with that, there can be synkinesis or involuntary movements of the muscles of face. And if the patient is not intervened immediately with the treatment, of course, the question is not there here. What is the treatment for it? You can give prednisolone. Along with that, you can also advise acyclovir here. So if the patient is not intervened early, the patient may develop long-standing right-sided facial palsy, and that will result in the flexion contractures or the permanent shortening of muscles on the opposite side. So what are some causes of this condition? The causes of this condition would be, since other than HSV, we also have HZV that may be resulting in this kind of facial palsy, that we call it as Ramsay-Hunt syndrome. And there are some other inflammatory infectious causes like Lyme's disease, and sometimes stroke, head and neck tumors, sarcoidosis, and GBS, the Guillain-Barré syndrome, can also result in this kind of presentation. And the last question is, what are the two differentiating features on UMN and LMN kind of facial palsy? The UMN, I'll show you that in the image. So you can see in this image, the lower half of face has the bilateral representation, and sorry, the upper half of face has the bilateral representation, and the lower half of face has only the unilateral representation. As you can see, if there is an upper motor neuron type of lesion, the patient will have a contralateral facial palsy where there is only involvement of the lower half of the face. So if there is an LMN kind of facial palsy, there is involvement of both upper half as well as the lower half of the face. If there is a UMN kind of lesion, the weakness of the facial nerve will be on the opposite side. If there is a lemon kind of lesion, the weakness will be on the same side. So here is Next question. The 72-year-old woman presents with the progressive memory loss. This is quite straightforward. So memory loss and urinary incontinence, and the image clearly shows you enlarged ventricles. So what is the most likely diagnosis for this patient? The most likely diagnosis would be normal pressure hydrocephalus. Of course, in the image, you can also see the effacement of sulci. Right, what are the main risk factors? The main risk factors, of course, here in this question, the increasing age is a risk factor, and along with that, the comorbidities like hypertension, diabetes, hyperdyslipidemia, Alzheimer's disease, all can be the risk factors. What are the main clinical features? The question asks the main clinical features. We have a clinical triad of NPH, that is cognitive impairment, urinary incontinence, and gait instability or gait disturbance. Right, what is the treatment for it? The treatment would be initially, as soon as you diagnose a case of NPH, first do a lumbar puncture and wait for 2 to 7 days. And so wait for 2 to 7 days, look for the improvement. If the patient is improving, then you can go ahead with the ventriculoperitoneal shunt that will drain off the CSF. So what is, okay, so these are the answers, and then we move on to the next question. The next question is, so a 68-year-old diabetic was brought telling that the patient had weakness of the right upper limb and lower limb, which he ignored for 2 days. Now he is brought in an unconscious state by his attenders, and you can see his CT brain. Right? What are the radiological features? So what are the radiological features here? You can see that there is this large hypodensity in the parietal lobe, predominantly in the MCA territory. And you can also see the midline shift. There is a compression of the ventricle on the left side, and you can see the midline shift also. Right? So the infarct is causing this mass effect, and because of that, there is a midline swelling. Right? And you can also mention the effacement of sulci and ventricles with the shift of the midline structures. You can see the effacement here. You are not able to make out any sulci and gyri on the other side. So how do you manage this patient? The patient has ignored the weakness for 2 days. It means that the patient, this weakness, I mean this edema has been progressing, and that is why, and the patient is unconscious now. So the primary treatment is not the thrombolysis or the dual antiplatelet therapy here. We have to give anti-edema measures first. Since the patient is also unconscious, you have to estimate the severity of the severity of the stroke using the NIHS score, and you also have to estimate the GCS. If the GCS is less than 8, try to intubate the patient and provide the patient with IV fluids and maintain the airway breathing and circulation. And after that, you also have to take the anti-edema measures. Right, the anti-edema measures would be to give mannitol, and if required, even despite giving mannitol, if the patient is not responding, then you may also go ahead with a decompressive craniectomy. And after that, you can give aspirin, right? Aspirin at a dose of 160 milligrams per day. Not every question in the exam, not every question may have 4 or 5 questions. As far as I see, I saw since while I was doing my DNB, I was there at 4 exams. So I can say approximately 3 to 4 questions are the usual norm. Sometimes if the examiner is expecting a larger answer, even 2 questions are also reasonable, right? So like I mentioned in the top right corner, so there is usually 4 and the timer that is located in the right upper corner like that. Now let's look at the next question. So a 68-year-old male, known case of diabetes, brought to the casualty soon as he had a fall in the bathroom and developed severe weakness of the right upper limb and lower limbs. So the BP on arrival is 180 by 100. CT brain image is shown here. Now what do you see here? This is nothing but the hyperdense MCA, right? This is a hyperdense MCA sign within in the initial hours, that is 2 hours, you will be able to see this hyperdense MCA sign on a CT brain. So what is the radiological feature seen here? You can see the hyperdense MCA sign. And what are the usual clinical features? Of course, you can see that there is a left-sided MCA infarct. So it is a dominant MCA territory infarct. So the patient will develop contralateral, that is right-sided hemiparesis, right-sided hemisensory loss, and right-sided homonymous hemianopia and global aphasia. Right? These are the common usual features that should be associated with this right MCA infarct. And what are some complications? The complications would be, like we saw in the previous image, there is huge mass effect, right? Because of edema. So there can be, if there is involvement of a large, I mean the MCA, there is a higher chance for the development of hemorrhagic transformation as well. So the complications would be a raised ICT, cerebral edema, hemorrhagic transformation, seizures, and a malignant MCA syndrome. Malignant MCA syndrome in the sense is a life-threatening condition where there will be massive cerebral edema and midline shift, like we saw in the previous question, and the patient may go into coma and death. Okay, that is malignant MCA syndrome. So how would you treat this patient acutely? Now the patient has come in window period now. So the patient was brought as soon as the patient fell and uh, was brought to the casualty. If the patient comes to you within 3 to 4.5 hours of the onset of stroke, you can directly go ahead with thrombolysis if there are no contraindications, of course. What do you give? You will give IV alteplase at a dose of 0.9 milligram per kg. 10% will be given bolus and the remaining will be given over by infusion over a period of 1 hour. And if the patient is not yet improving within 24 hours, you can also go ahead with the endovascular therapy, right? And here you see that the blood pressure on arrival is 180 by 100. If the patient is going for thrombolysis, then the maximum tolerable blood pressure would be 185 by 110. But if the patient is being not taken for thrombolysis, this is not the case. Not in this case. If the patient is not being taken for thrombolysis, then the blood pressure control is 120 by 210 by 120 millimeters of mercury. These are some important points that you have to keep in mind, maybe asked in the question or in the viva. So how do you treat this patient acutely? Firstly, you will give thrombolysis, and after that, if the patient is not recovering, then you may also go ahead with endovascular therapy within 24 hours. And if you thrombolyze the patient, then only after 24 hours you can give aspirin. Right? The current guidelines say you can give dual antiplatelet therapy only if there is a minor stroke or a TIA. So in these patients, the dual antiplatelet therapy is not required. And if the patient is thrombolyzed, you can start aspirin after 24 hours. But if the patient is not being thrombolyzed, you can straight away start immediately aspirin at a dose of 160 milligram per day. These are the answers again. Zoom in and look at this protocol for the acute management of stroke. Right, I'm sorry you won't be able to identify it in this video because the letters are quite small. So let's move on to the next question. So a 30-year-old female, she's a known case of SLE, presents with acute onset of weakness and numbness in all the four limbs. So the patient is having an acute onset quadriparesis. So what is the most likely? Of course, the image shows you hyperintensity in the cervical cord. So the most likely diagnosis would be transverse myelitis, right? The most likely diagnosis would be transverse myelitis. And what are the some other autoimmune causes of quadriparesis? Some other autoimmune causes of quadriparesis that you would consider are the multiple sclerosis, neuromyelitis optica, or Guillain-Barré syndrome. Okay, all these are the possibilities. Before you look at that image, all these immune causes can also be considered. How would you treat this patient? This is because of an autoimmune process, and hence you will also you will have to start the patient on high dose corticosteroids, usually methylprednisolone, followed by tapering with the oral prednisolone gradually. If the patient is not responding, then again you can go ahead with the high dose methylprednisolone, pulse dose methylprednisolone, or intravenous immunoglobulins or plasma exchange. You can also use cyclophosphamide or rituximab in these patients, right? So if you see a clear hyperintensity like this, and if it is if you're able to make out the clear borders of it, and if there is a long standing history you should also think about the syringomyelia here, right? But syringomyelia, if the examiner wants you to answer syringomyelia, he'll probably give the clinical description of dissociative anesthesia, where the pain and temperature are impaired and the vibration and position sense are preserved, right? The posterior columns are preserved, whereas the anterior spinothalamic tract are involved here, as in case of syringomyelia, not here, right? Let's move on to the next question. So, a 72-year-old woman presents to the memory clinic with her daughter, who reports that her mother has been increasingly forgetful, confused, and agitated in the past year. She also complains of visual hallucinations, difficulty sleeping, and episodes of acting out of her dreams. Right? What does this question say? I mean, the questions on dementia are not very frequent. You may have a question commonly on Alzheimer's disease and Parkinson's disease, but this question is little different from them. So you can see here the patient is having the memory disturbances. That is, the patient is having forgetfulness, right? The patient is having forgetfulness, and the patient is having hallucinations, right? Visual hallucinations and episodes of acting out of her dreams. Usually, while we are sleeping, the patient we also have the motor paralysis, right? But if the patient is having this particular disease where the patient will be doing the violent movements of the hands while the patient is dreaming as well. So, okay, this is the characteristic description that should be there in Lewy body dementia. Here there is dementia, and the supportive features for the Lewy body dementia is one. Here we have the REM sleep behavioral disorder, and we also have the visual hallucinations. All these point towards the diagnosis of Lewy body dementia. And what are the main cognitive domains? See, we have memory, attention, language, executive function, and visuospatial functions. So these are the cognitive domains. The cognitive domains. But in Alzheimer's disease, if you talk about Alzheimer's disease, initially the memory, particularly episodic memory or the semantic memory, is firstly involved, and then language, and further the patient may not be able to do any daily activities as well. That is the usual course of disease in Alzheimer's disease. But you can see here the cognitive domains that are involved firstly in the Lewy body dementia. That was the question here. What are the main features of cognitive domain that is impaired in this condition? The main cognitive domains that are involved here are the visuospatial defects, the visuospatial function or visuospatial perception, and the executive function. All right, these are usually the last to be involved in Alzheimer's disease. These are first to be involved in Lewy body dementia. And what is the next question? What are some possible differential diagnoses for this patient? So you can write all the other causes of dementias like Alzheimer's dementia, vascular dementia, frontotemporal dementia, normal pressure hydrocephalus, and Prions disease. And just for sometimes there can be some identical questions. We may not frequently read them. That's why I'm just focusing on them. So in the question, if there is history of stroke or TIA, if there is history of stroke or TIA, then you can go ahead with the vascular dementia. If there is Parkinsonism in the question, see, in Lewy body dementia, of course, in this question, the Parkinsonism has not been mentioned. But if the patient develops the motor features of Parkinsonism plus a dementia at the same time or within the 1 year of the development of motor features, then you can also label it as the Lewy body dementia, right? That is another kind of clinical presentation. And if the patient, of course, gives a history of stroke in the question, it can be vascular dementia. And if there is abnormality in the behavior, if there are frontal release signs, then you can go ahead with the frontotemporal dementia. And if there is, of course, the clinical triad of gait dysfunction, urinary frequency, and dementia, you can go ahead with NPH. If there is rapidly progressive dementia and myoclonus, right? Rapidly progressive dementia and myoclonus, rapidly progressive dementia and myoclonus will give towards the Creutzfeldt-Jakob disease. This is just for your information. These questions are quite deep. They may not be asked in the exam, but sometimes academic questions may come. When I wrote the exam, there was a question on nerve conduction studies. Okay, so of course I left that question, but try to read about nerve conduction studies. Of course, these kind of academic questions may come in the exam sometimes, because examiner does not want you to answer all the questions, right? So 20% of the questions, approximately 3 to 4 questions, may be quite tough. Okay. So what are some non-pharmacological and pharmacological interventions that could help this patient and her caregiver, right? So the patient is having dementia, right? All the cases of dementia, you will have to give the drugs which will increase the acetylcholine in the neuromuscular junction. They are nothing but the cholinesterase inhibitors like donepezil, rivastigmine, galantamine. Along with that, so what are the pharmacological interventions? The patient needs to have a caregiver, and the patient should have a safe and familiar environment. The patient gets quite agitated in a unfamiliar environment. That's why it is also important to provide the patient with a familiar environment with adequate lighting, okay, and minimal noise. The last question was what are the complications? I think I missed it. So what are the complications the patient may develop? Fractures, aspiration pneumonia, because dementia, the patient may be prone to falls, right? Now the next question. So a 65-year-old man presents to the neurologic clinic with a 6-month history of progressive weakness and wasting of his right hand. He denies any sensory symptoms, bowel and bladder dysfunction, cognitive impairment. So the tongue is atrophied and has fasciculations. Jaw jerk is positive. His reflexes are brisk throughout, with the bilateral Hoffman's and Babinski signs. MRI brain is normal. So what do you see here? Of course, the MRI brain is normal. That's what he says. And what do you see here? There is progressive. It is progressive weakness and wasting of the right hand. So the right hand is having an LMN kind of palsy. He denies any sensory symptoms. This is a classical description. There won't be any sensory symptoms or bowel and bladder dysfunction. And the tongue is atrophied and fasciculations. Again, this is kind of a bulbar LMN palsy, right? And the jaw jerk is positive, right? Jaw jerk is positive, and his reflexes are brisk. What is this? The reflexes are brisk with bilateral Hoffman's and Babinski sign. This indicates that there is UMN palsy as well. So the combination of upper motor neuron and lower motor neuron kind of palsy is seen with the motor neuron disease, particularly amyotrophic lateral sclerosis. The word itself tells you there is not much to remember here. Amyotrophic lateral sclerosis, amyotrophy, that is lemon, only in the lemon kind of palsy you will get the amyotrophy, atrophy, and the lateral sclerosis. What is the lateral column? That is there in the spinal column. Lateral column is nothing but the corticospinal tract, right? So the word itself tells you there is involvement of LMN as well as UMN here, right? So the most probable diagnosis will be motor neuron disease with the amyotrophic lateral sclerosis. And what is the main criteria used to diagnose this condition? The latest criteria is the Gold Coast criteria. Okay, Gold Coast criteria. So what are some possible differential diagnoses for this patient, and what tests would be you should do to rule out them? So other possible differential diagnosis would be multiple motor neuropathy, Kennedy's disease, myasthenia gravis, and cervical spondylotic neuropathy. So these are the other possible differential diagnoses: multifocal motor neuropathy or Kennedy's disease, myasthenia gravis, cervical spondylosis, right? So what are some genetic and environmental risk factors for this condition? Of course, everybody must know the superoxide dismutase gene, so SOD, and fused sarcoma gene, FUS, and after that TARD BP gene and C9 or 72. So these are some genes that are implicated in the development of the amyotrophic lateral sclerosis. And what are some pharmacological interventions? The only two drugs that have been approved in the management of ALS are riluzole and edarvone. Right, riluzole and edarvone. Of course, the riluzole is a anti-glutaminergic agent, and edarvone is a free radical scavenger. And again, here, this is the old one. Now, remember for the answer, I didn't change it. The Gold Coast criteria. Now, the next question. A 75-year-old woman presents with the progressive memory loss, confusion, and personality changes over the past year. Her family reports that she often repeats herself, forgets appointments, gets lost in the familiar places. She also has a difficulty of language and naming objects, performing daily tasks. Right? So, what does this question say? There is obviously the memory impairment in the cognitive domain. There is memory loss, and there is personality changes as well. He forgets the appointments. Again, this also tells us the memory loss, loss in familiar places. And there is difficulty in language as well. And of course, the naming objects, right? And difficulty in performing daily tasks. All this history is suggestive of Alzheimer's disease, right? So, what is the most likely diagnosis? The diagnosis will be Alzheimer's disease. The most likely diagnosis will be Alzheimer's disease. Why is that? Because there is involvement of memory, language, and the patient is not able to perform the daily tasks. Right. So, what are the two main pathological features of this disease? Everybody knows it. They are amyloid plaques and the neurofibrillary tangles. Neurofibrillary tangles are nothing but the groups of tau protein, right? Microfibrillary tau protein accumulation. So, what is the most common genetic risk factor? The most common genetic risk factor would be ApoE, right? ApoE4 is associated with increased risk of Alzheimer's disease. ApoE2 is associated with decreased risk of Alzheimer's disease, and ApoE3 is neutral, right? ApoE3 is neutral, and this is the most common one. What are some pharmacological and non-pharmacological interventions? Again, since the patient is having dementia, pharmacologically, what you will give? You will give the acetylcholinesterase inhibitors that are donepezil, rivastigmine, and galantamine. And you can also use the NMDA receptor antagonists and non-pharmacological interventions, similarly like that of the LBD. So, what are some other differential diagnoses that are to be considered? Again, you can write all the causes, all the diseases that can result in dementia, like LBD, FTD, Parkinson's dementia, NPH, CGD, Creutzfeldt-Jakob disease. What are some reversible causes of dementia? So, this is an important question. What are some reversible causes of dementia? We have the vitamin B12 deficiency, thiamine deficiency, hypothyroidism, infections like meningitis, encephalitis, usage of the benzodiazepines or sedatives, and increased usage of opioids. All these will result in reversible dementia. So, here you can see the atrophied brain parenchyma. That is depending of the sulci. This is a normal one, and here you can see enlarged ventricles as well because of the predominantly atrophied temporal lobe seen in Alzheimer's disease. So the next question. A 56-year-old woman with history of diabetes mellitus and gastroparesis presents with complaints of tremor, stiffness, and slowness of movement in both upper limbs for 6 months. So what is the most likely diagnosis for this patient? So the patient is already having the diabetes mellitus and the gastroparesis. Now the patient has developed tremors, stiffness, and slowness of movement. Of course, the patient is having tremors. Stiffness could be rigidity, and slowness of movement. What do we call it? Bradykinesia. Right? This is a straightforward question. And sometimes the question can be, what are the pre-motor symptoms? So sometimes prior to the development of these motor symptoms, that is a tremor, rigidity, and bradykinesia, the patient may develop a pre-motor symptoms. They are constipation and anosmia. These can be there even for a decade before the development of motor symptoms, right? Constipation and anosmia. Sometimes the REM sleep behavioral disorder as well. These kind of presentation can be there prior to the development of motor features of Parkinson's. So what is the most likely diagnosis here? The most likely diagnosis would be Parkinson's. What are its cardinal features? The cardinal features are nothing but trap, tremor, rigidity, akinesia or bradykinesia, and postural instability with gait dysfunction. So those are the cardinal features. And what are the specific neuroimaging modality that is required for this patient? Since there is the depletion of dopamine in the nigrostriatal tract, so if the patient asks the pathology, there is depletion of dopamine in the nigrostriatal tract. Right, there is diminished dopamine, right? So there is, if you do an investigation based on the dopamine uptake, then there will be diminished uptake. So what will you do? You will do the dopamine based SPECT or a PET scan, right? Dopamine uptake SPECT or a PET scan. So what are the drugs that may result in these symptoms? Not the question asks you what are the drugs that may result in the symptoms? What are the drugs that are implicated in the development of Parkinsonism? They are typical antipsychotics. Since they are D2 blockers. So typical antipsychotics like haloperidol, promethazine, phenothiazines, all these drugs, and then metoclopramide, prochlorperazine, cinnarizine, and especially lithium. Okay, these are some drugs that may result in the symptoms. What are some medications for gastroparesis that do not cause the symptoms? So if the patient had secondary Parkinsonism, you may want to prevent the usage of metoclopramide. So other medications that you can use for the gastroparesis are, you can use domperidone or you can use any prochloropride kind of drugs, right? So these are some drugs. These are the answers again. So these are some questions that I gave some importance to, approximately 11 or 12 questions, and also go ahead with these other 12 topics as well. Right, Wernicke's encephalopathy, hemorrhagic stroke, SAH, temporal lobe epilepsy, multiple sclerosis. When I was writing the exam, there was a question on internuclear ophthalmoplegia. Read about SACD, GBS, meningitis, encephalitis, alcohol dependent syndrome, syringomyelia, and JCS. These are some common topics where the examiner may put some questions. I gave you a brief idea about how the questions can be, and you don't have to write the question answers in the sentences. You can simply write in simple words straight to the question, because it takes a lot of time for you to read the question if it is long, right? If there are 4 questions within the 4 minutes, you may not be able to write in the sentence format, so try to incorporate the keywords into the question. Okay, so that's the end of our discussion for today. I'll meet you in the next class. Thank you.